Incredibly, septicemia affects 50 million patients every year, and that accounts for 10 to 11 million deaths globally. For all of us, that translates as one family losing a loved one every 2 to 3 seconds.
In this episode, we examine the global burden of sepsis through the COVID-19 lens. We've got some of the top experts from around the world focusing on the practicalities of moving the needle, so to speak, in the fight against sepsis.
We're proud to collaborate with MSD on this educational project. MSD is committed to combating infectious diseases, to tackling antimicrobial resistance, and to coming up with new ways to face this current pandemic.
So wherever you are in the world, we ask that you take a moment to acknowledge the traditional custodians of the land on which you stand.
Welcome to Codazero.
Hello and welcome. I'm Naomi Hammond. I'm a critical care nurse researcher, and I'm super pleased to be able to host the first Coda Cure session on sepsis. Today, I am joined by 4 experts in sepsis and antimicrobial stewardship. So firstly, I'd like to welcome Elizabeth Hermsen. Elizabeth is an infectious disease pharmacist, and she's the global head of antimicrobial stewardship at MSD. And you are coming to us from Omaha in the US. So welcome, Elizabeth. Next, I'd like to welcome Flavia Machado. Flavia is an intensivist, a researcher, and the CEO of the Latin American Sepsis Institute in Sao Paulo, Brazil. So welcome, Flavia.
Thank you.
Next, we have Derek Angus. So Derek is also a clinician researcher and currently the Chief Healthcare Innovations Officer at the University of Pittsburgh Medical Center. He's also very well known for his role as the Associate Editor for JAMA. So welcome, Derek.
Thank you very much, Naomi.
And lastly, in the studio with me in Sydney is Simon Finfer. So Simon is a clinician researcher. He's our expert clinical trialist and our founder and CEO of the Australian Sepsis Network. So welcome, Simon.
Thanks, Naomi.
So over the next hour, we are going to be discussing sepsis in the context of the current pandemic. We would love our audience to get involved, so please use the question box, which is a red and white box on your streaming platform, to post your questions. You can also upvote other people's questions if you find those of interest, so they will be more likely to get through to me in the studio to ask to our experts. There's also a chat function that you can use, and please post to your socials using the hashtag Codazero. Okay, so Simon, I would like to start the session off with you. So sepsis has obviously been a challenge for clinicians in respects to the defining, the recognising and the treatments. However, over the last few decades, we've become extremely good at trying to work out these things and improving outcomes for our patients. So with the novel coronavirus and the disease that it causes, it feels like we are back at the beginning again of discovery. However, it does seem that COVID-19 is very much like ARDS and sepsis. So is it, and if it is, why are we not calling it that?
Yeah, thanks, Naomi. It's a very interesting question. And as someone who's been working and interested in researching sepsis for probably longer than I'd like to admit, getting on for 4 decades now, it's a little frustrating, to be quite honest, because, you know, sepsis, I mean, it's a syndrome. There's no diagnostic test. You can't do a blood test for it. You can't take an X-ray for it. You can't do a tissue biopsy. So it's a clinical syndrome. And it's been redefined a few times. The latest version, Sepsis 3.0 apparently, we might have 3.1, whatever, talks about sepsis is life-threatening organ dysfunction due to a dysregulated host response to an infection. So COVID-19 in its clinical form, because obviously there's an enormous number of asymptomatic in people, carriers, infected, whatever, they're asymptomatic, but in its clinical form, it's sepsis. You know, I mean, we've got people having terrible multi-organ failure, and I think I should have it's not a disclosure of interest, but an admission of innocence, if you like, in that Australia up until very recently, we have been very effectively unaffected. Now, Flavia, for instance, and Derek are working in countries and in ICUs profoundly affected. So my personal experience of treating people with COVID is limited in the ICU to half a dozen cases. So nothing yet, and hopefully, fingers crossed, it could stay that way. But to me, it's kind of a bit frustrating because I'm reading all these things in the press, in the medical press, and they're describing sepsis, and they're talking about things that we have talked about for 20 years, multi-organ failure, and it's being called all sorts of things other than sepsis. So there's a tiny little bit of data which I will show. It's now disappeared, so I don't know. Hopefully it's come back. Hopefully people can see this. Now, this was quite an interesting little study because we're hearing about cytokine storm as though it's something new and novel. And yet, if this slide shows in the top panel are IL-6 levels for patients with COVID. And this is this cytokine storm. But in the bottom panel are levels measured in people with kind of common or garden ARDS, if you like. And those levels are vastly higher. Now, clearly, it's a dynamic process, and it depends on exactly when you're measuring, etc. But this idea that COVID is some sort of novel thing, and it's causing this massive cytokine storm, as this study was titled when it was publication, is cytokine storm relevant to COVID-19? Because perhaps it's more of a cytokine breeze. But nevertheless, the pathophysiology, for instance, if the post-mortem studies that have been done of patients with with COVID-19 who've died and looking at their lungs, the pathology is exactly the same as ARDS. It's neutrophil infiltration, it's hyaline membrane formation, it's pulmonary edema, but it's not being called necessarily ARDS. So there's a little bit of frustration. It's good in a way because this is presenting us with an opportunity. I think I won't go into the kind of the research side of it, because I'd like to hear from Derek on that. He's right there at the coalface. He's at JAMA. He's being sent, I'm sure, thousands of papers every 5 minutes. So he knows what's going on out there in the research world. But maybe people are making, maybe if people think about this more in the lens of sepsis and ARDS, we can stop making some of the mistakes we've made in sepsis research over the years, because you do look at it and see there's things like, for instance, IL-6, people have measured IL-6 and it's raised, so therefore we must give some sort of IL-6 inhibitor or antagonist, because if we've measured something and it's out of range, we've got to fix it and then the patients will get better. This is what we've been doing in sepsis research for decades. And how many drugs do we currently have licensed to treat sepsis? 0. So, yeah, it's interesting. I would like to see people talk about it more in the sepsis lens, because, that way we can harness some of this enormous attention that's being given to COVID, and use it to help us to deal with this sort of, it's endemic. We hear about epidemics of obesity. Now, pretty much the only thing I remember from my community medicine teaching at medical school was an epidemic. You was required to have an increase in incidence followed by a reduction in incidence, and a pandemic, the same thing. It's up and down. Sepsis is endemic with an increasing incidence. So it's hopefully we'll get on top of COVID. Hopefully, for the first time ever, the human race might produce a vaccine. But when we've done that, hopefully we do that, we'll still have what you might call common or garden sepsis, killing, as Roger said, tens of millions of people.
Yeah. Thanks, Simon. So COVID is sepsis. So do you think that COVID-19 should be getting all the attention and funding that it is getting?
Yeah, that's an interesting question. I just hit you with a little bit more data. I mean, I took this snapshot. This is obviously from Johns Hopkins. They're tracking COVID. Their data is being reported very regularly. And I took this at approximately 6 months into the pandemic. So you can see the total confirmed cases of just over 17 million and 673,000 identified deaths. Now, if you take 6 months of sepsis, according to the global burden of disease data, we would expect to see 25 million episodes, cases, so more than we're seeing with COVID in a 6-month period, but 5 million deaths. So instead of these 673,000, we would have 5 million deaths if I was putting up a slide of sepsis. Now, obviously, there are many caveats there because the data is not being collected everywhere. There was a very interesting research letter, which I'm sure Derek is familiar with, in JAMA, which looked at actually the number of excess deaths in the US death data. So when the US was saying that we have 120,000 deaths due to COVID, when you looked at, which was January to April of this year, and then they looked back 5 years and they age adjusted it and did various things that one should do with such observational data. And they said the actual excess number of deaths in the US over what would be expected was 180,000. So we could safely assume that even in the US, where there is good data, there may be 50% more deaths being reported. So if we're currently talking about 150,000 deaths, it's probably more like 225,000. And that's in a country that has, we hope, reasonably good death certification data. So around the rest of the world, I think we can expect that actually the number of deaths is far more. So numerically, I could make an argument, although I wouldn't make it very strongly, that sepsis is actually normal. In this 6-month period, we would have seen far more deaths from sepsis than we have seen from COVID. There are clearly reasons why COVID is getting the amount of attention it's getting, because it's spreading, it's going global, its potential to do far more harm is clearly there. There are some striking differences, I have to say, about COVID, and particularly its epidemiology, because in those 11 million deaths that the global burden of disease estimates from sepsis, that was the 2017 data. The real burden of that was in sub-Saharan Africa, which really doesn't show up very red on this data at all, and also in the under 5s. Whereas, about nearly half those 11 million deaths occurring in children under the age of 5, and a lot related to diarrheal diseases, etc. Whereas COVID seems, gratefully, we should say, to be sparing the pediatric population as best we can understand. Sepsis hits this very young population, then it drops off, and then it goes back up with age. In fact, your risk of dying from anything tends to go up with age. But there's this peak of very young children. With COVID, we don't seem to be seeing that.
Okay. Thanks, Simon. So I want to go to audience questions, but firstly, supposedly Derek never allows you to speak for this long without interrupting. So I was wondering, Derek, if you wanted to make a very quick comment at all, or observation at all about what Simon has.
He's only allowed to agree with me, okay?
You're only allowed to agree with him. Well, we'll see. So Derek, just a quick comment.
Totally agree with some of the things Simon said. So I think COVID is both a sepsis syndrome, but it has some unique flavors. So there's two ways in which I think it's not sepsis. One is much of the pathophysiology is very similar, but there also is some evidence, for example, of a relatively unique endovascular opathy, an endovasculitis, whatever we want to call it, that looks a little unusual in comparison to traditional sepsis. And the other thing is, for the vast majority of patients, depending on whether you believe remdesivir works or not, the pathogen is proceeding unabated. Whereas in most sepsis, we will have antibiotics that will control the pathogen, and then we're left largely dealing with the host response to what is often now an eradicated pathogen. So I think it's definitely in the family of sepsis syndromes, but it definitely has some unique features, and it probably needs a two-pronged approach. Strategies specifically targeting COVID, and strategies totally trying to learn lessons learned from the broader research agenda in sepsis and areas.
Thanks, Derek. So I'll go to audience questions now. Thank you for sending these through. So the first question, Simon, why is the host response so variable in sepsis?
Well, I think just to answer that question, but also to address Derek's comment, the really interesting thing to me about COVID is we have this massive incidence of a sepsis syndrome, whatever, let's call it sepsis. Okay, we have a massive incidence happening, identifiable from one infecting organism. That is an enormous opportunity, because normally we look at sepsis and it's this hodgepodge, average chicken soup, noodle soup kind of sepsis that's abdominal sepsis, respiratory sepsis that's viral and bacterial and so on. And we're taking all the average of this and then trying to find a treatment for it. Here we've got something that is a single microorganism, and it gives us an opportunity to really hone in on certain things from a research and treatment point of view. And it is demonstrating to us, because we've got this single organism, this single virus, that people are able to look at things, for instance, the genetics of ACE inhibitors and ACE receptors and so on, and identify that there's already been some quite nice papers looking at genetic heterogeneity, families that have particular genes to do with ACE receptors, for example, who are either very susceptible or not susceptible based on that. So you've got this single infecting organism, and you can look into this. Why is the host response so variable to this particular virus? And you might find that people who are incredibly sensitive to COVID and it's going to kill them have some genetic variation that's going to make them resistant to something else. We already know that there are various genetic profiles that make you particularly prone to sepsis or a pronounced inflammatory response to something. So a lot of it, I think we're going to, again, COVID is providing us with an opportunity to study with one particular infecting organism. And we can, I think, make a reasonable assumption that those same variation in response would be true for lots of other infecting organisms. The problem is we just don't get hundreds of thousands and millions of cases of them in a short period of time with the entire world's scientific community focused in on them. So the opportunity to learn about why that heterogeneity exists is not so obvious and not so easy. But again, a huge opportunity out of this, not only for those of us in the sepsis community, if you like, to say, okay, what's happening now with COVID is highlighting many of the issues that we've been talking about, and nobody's been taking much notice of us in terms of it's not true, but we would still like more attention from funding agencies, governments, etc., on, to deal with the 50 million cases and the 11+ million deaths in the same way that we have attacked COVID.
Thanks, Simon. So I think we'll move on now to Elizabeth. So Elizabeth, we know that one of the first-line treatments of sepsis is timely and appropriate antibiotics, but also on the other side of things that antimicrobial resistance is a real threat, and particularly in lower middle income countries, which Flavia could contest to. So can you, Elizabeth, from your perspective, what are the key issues that COVID-19 pandemic has highlighted for antimicrobial resistance and stewardship?
Sure, thank you for the question. I think, first of all, the SARS-CoV-2 virus, the virus that causes COVID-19, has really highlighted our vulnerability to infectious diseases in general. We have now been able to experience firsthand the public health and economic costs of a pandemic, of infectious diseases. And we know now what it means to not have effective diagnostics, treatments, and vaccines when we need them. So we just saw some of the numbers about the deaths due to COVID-19, and using that same Johns Hopkins tracker, as of yesterday, there are about 690,000 deaths around the world. But we have to account for the fact that COVID-19 was a surprise. It was an ambush. We didn't know that it was coming. So that is a horrible number. And we don't like to hear about that amount of deaths due to anything. But AMR, or antimicrobial resistance, we know we have a problem with, yet we still today have about 700,000 deaths due to AMR every year. And that again highlights the impact that not having effective diagnostics, treatments, and vaccines where we need them can have. And for antimicrobial resistance, where we know it's a problem, we just simply shouldn't be in a situation where we don't have effective diagnostics, treatments, and vaccines. So with COVID-19, another thing that we've seen from the lack of diagnostics, treatments, and vaccines is increased antibiotic use. And we know that antibiotic use is a key driver of antimicrobial resistance. And so some of the use that we're seeing with COVID-19 is likely appropriate, but much of it is probably inappropriate. And this is where antimicrobial stewardship, or AMS, comes in. And so I do just want to take a moment to clarify what I mean when I talk about antimicrobial stewardship, or AMS, because oftentimes when you use that term, what people first think about is the so-called antibiotic police. And unfortunately, that is due to how antimicrobial stewardship is often practiced, which tends to be somewhat of a drug cost minimization program. But what antimicrobial stewardship, or AMS, is really about is the responsible use of antimicrobials. So selecting the right drug, dose, and duration for an accurate diagnosis in the right setting of care, and de-escalating therapy when appropriate, in order to optimize patient outcomes and minimize those unintended consequences of antibiotic use, such as AMR. So this is what I'm referring to when I talk about antimicrobial stewardship, not the antibiotic police. So COVID-19, I would say, has really highlighted the impact of infectious diseases and our vulnerability to infectious diseases. And again, the importance of having effective diagnostics, treatments, and vaccines, and the importance of using those tools responsibly.
Thanks, Elizabeth. So you mentioned that you're seeing an increase in antibiotic use. So why do you think this is, particularly that COVID-19 is a virus and antibiotics don't work against viruses?
Well, that's a great question, and a very important point to emphasize is that antibiotics work against bacteria, not viruses. So why are we seeing increased antibiotic use with COVID-19? I think there are two primary reasons for this. First, we've actually learned from sepsis the importance of early appropriate therapy. We know that when you have delays in appropriate therapy for sepsis, you see increased rates of mortality. And so clinicians are aware of this, and this concept has been extrapolated to other areas of infectious diseases as well. And clinicians want to get something on board as soon as possible because, again, we know the importance of early appropriate therapy. In addition to that, many of the features of COVID-19 are difficult to differentiate from bacterial infections. You have fever, shortness of breath, hypoxia. So you have a situation where clinicians know the importance of early therapy, and they have a clinical syndrome that might be difficult to differentiate from bacterial disease. And then on top of that, we don't have widespread availability of effective treatments for COVID-19 yet. And so in this situation, again, clinicians want to get something on board for whatever may be causing the issue as soon as possible. And in some cases, that means antibiotics. The second primary reason that I think we're seeing this increased use of antibiotics is due to our experience with influenza in the past, and what we've seen as relatively high rates of bacterial co-infection or secondary bacterial infection. So rates up to about 35% in influenza patients. So clinicians, I think, with COVID-19 have a high suspicion for secondary bacterial infections or co-infection. Now, some studies with COVID-19 have shown that that rate of co-infection is actually lower, so closer to about 8% co-infection or secondary bacterial infection in COVID-19 patients. Yet 72% of COVID-19 patients are receiving antibiotics. So a caveat, though, to that lower rate of bacterial co-infection is that those bacterial co-infections or secondary infections are still a significant contributor to the mortality that we're seeing with COVID-19. So some studies have shown that about 50% or half of the patients with COVID-19 that die have a bacterial co-infection or secondary infection. So this relatively low rate of bacterial infection, in addition to the high rate of antibiotic use and the high mortality burden in those cases where co-infection is actually documented, really highlights and emphasizes the need for antimicrobial stewardship again.
Yeah, so thank you, Elizabeth. I'm just wondering, Flavia, if you'd like to make any comments on this, excuse me, particularly around that in Brazil, I'm sure the rates of antimicrobial resistance are high. So from your perspective, do you want to make any comment?
Yeah, I fully agree with everything and all the concerns that Elizabeth has raised. And we have to put it in context because, yes, in low and middle income countries, healthcare-associated infections and multi-drug resistance are quite much more common than in high-income countries. We already know that by the literature. And I believe that COVID just strengthens this weakness. What I mean, we are without supplies to do proper, to deal with these patients. We have a shortage of the stewardship personnel and also supplies for this. We are now with difficult, for instance, to measure colonization of our patients. And as Elizabeth has mentioned, although co-infection and secondary infection seems to be low based on high-income country data, I'm not sure about that. Yeah, we have a huge problem with that. Our mortality rates are much higher. And I believe that most of our patients that die, they do have a secondary infection, which raises a visceral sickle, where we have to do a very broad spectrum empiric therapy when these patients are severely ill. And then we are just maybe overusing antibiotics. And there is another issue. There is a cultural problem. I believe that regardless if you are in a high-income country, a low or middle income, nobody has 100% compliance with hand hygiene. And now that we are working protected with the gloves, for instance, it's different because one of the drivers for hand washing is the sensation that you touch the patient and now you're dirty. So you have to clean your mouth. And with the gloves, it does not happen. So it's much, much worse to train people. And there's another issue. We have a shortage of well-trained healthcare workers because we double our ICU beds. And a bed needs healthcare workers to work with. So there are quite a lot of untrained people. So it's a huge issue. It was a huge issue. And now it's much bigger.
Yeah. Thanks, Flavia. That's a really interesting perspective, particularly about the feeling protected as a health professional. So, Elizabeth, we'll just maybe touch on the roles of vaccines and their role in antimicrobial resistance, and if a COVID-19 vaccine would help.
Sure. So vaccines can really play an important role in antimicrobial resistance by preventing infections. And through preventing infections, there are two primary things that vaccines help with. They can reduce the carriage and transmission of antimicrobial resistant pathogens, and they also reduce the presence of clinical symptoms that may result in antibiotic use. So when we think about vaccines, we can think about three broad categories in the context of helping with antimicrobial resistance, or AMR. So the first category would be vaccines that prevent commonly acquired bacterial infections that subsequently would result in relatively widespread antibiotic use for those bacterial infections. The second category would be vaccines that prevent specific infections due to an antimicrobial resistant organism. So something like TB or gonorrhea. And again, that's the case where those vaccines would also help prevent the carriage and transmission of those specific antimicrobial resistant pathogens. And then the third category is vaccines against viral illnesses that ultimately may result in antibiotic use, whether it's inappropriate antibiotic use to treat the primary viral infection, which we know antibiotics don't work against viruses, or appropriate antibiotic use to treat a secondary bacterial infection like we were just talking about. And so your question about would a COVID-19 vaccine help address antimicrobial resistance? Yes, because a COVID-19 vaccine would fall into that third category of preventing a viral illness that ultimately may result in antibiotic use. So all three of those categories that I just talked about would help reduce overall antibiotic use. And as I already mentioned, we know that antibiotic use is a key driver of antibiotic resistance. But what's important to mention, so for COVID-19, I believe now there are over 160 vaccines that are in development, with about 25 of those in human studies. So I think we can feel relatively optimistic about the likelihood of a COVID-19 vaccine. But vaccines only work and will only help address antimicrobial resistance if people get vaccinated. And vaccine hesitancy is a key contributor to infectious disease outbreaks around the world, as we've seen with measles. We've also seen polio in the Philippines. And so public trust and confidence are really at the core of successful immunization programs. And we need to remember that, not only for antimicrobial resistant relevant vaccines or specific vaccines, but for all vaccines, including future COVID-19 vaccines. And it's really concerning with COVID-19 because one example is just a poll that was recently conducted by CNN in the United States suggested that about a third of Americans would not get vaccinated against COVID-19, even if a vaccine was readily available and low cost. And so this public trust and confidence is really an issue that we need to address, and it's relevant, like I said, for all vaccines. AMR and COVID-19.
Thanks, Elizabeth. You've actually answered the audience question around the main hurdles, I think, with COVID vaccine in respects to vaccine hesitancy. But Simon is desperate to ask a question.
Yeah, I'm really worried that, there's like, as you said, there's I thought it was 120. I mean, that was probably yesterday. Now there's 160. And they're going into clinical trials very quickly. We hear even respected people like Anthony Fauci talking about having one by the end of the year. I'm really worried. I mean, we all want a vaccine, and there's the worrying data from people who've been infected that the antibiotics maybe only hang around, get the right word out. Not the antibiotics; they hang around forever. The antibodies might only hang around for a month or 3 months. So we could have a vaccine that produces immunological response. My worry is around this kind of vaccine hesitancy, anti-vax movement, etc. If we rush these vaccines in and go and vaccinate a whole lot of people and cause a whole lot of adverse effects, we could harm the well-established vaccination programs where we know we have safe vaccines that save millions of lives. If people rush too quickly and start vaccinating people and that we see a whole load of side effects because they haven't been through the normal development process of a vaccine, it strikes me as it's just a little bit worrying.
Yes, I agree with you. And I think the message that we need to keep sending is that speed is important. And in a situation like this, we certainly recognize that speed is important, but not at the expense of safety and efficacy. And so we absolutely need to make sure that the vaccines are safe, effective, and durable. The point you brought out about the duration of immunity. That's also very important when you think about development of a vaccine.
Thank you, Elizabeth. Thanks, Simon, for that. So I'd like to now move to Derek. So Derek, I want to discuss the explosion of research that we've had since COVID-19. I went on to PubMed yesterday and put in the search term COVID-19, and it returned more than 37,000 articles. So that's like close to 200 a day if you look at the beginning of the year. And then on clinicaltrials.gov, there's just under 3,000 registered clinical trials. So whilst this is an amazing research response, do you think our research standards have lowered since COVID?
Well, my view on this, to some extent, I would say I hope so. And by that, what I mean is a lot of research standards, the word standard is imbued with way too much prestige than it necessarily deserves. I think it's important to remember that when we talk about standards, what we're really just talking about are choices. So, for example, we might choose that we're going to say a standard is that all registration trials should be placebo-controlled. But that is a blanket statement across all conditions. And there are absolutely research questions where the relative gain for a randomized trial of having a placebo is near nil. Sometimes the placebo doesn't even cause blinding. And sometimes blinding just isn't that necessary because there's no practical ability for patients or clinicians to modify the trial, even if they knew the assignment, or modify the outcome. So these sort of many of the blanket standards that we would have in, say, I would call peacetime, it's totally worthwhile asking oneself when we try to get onto a wartime footing, to be very careful about not hog-tying ourselves with standards that just tie us in knots. Having said that, it's also true that we don't want the wild, wacky West. We have I didn't know how many papers have been published, but I do know how many papers we've got at JAMA. We've had 15,000 papers
Our
this year.
timers stopped working. We can't tell.
Wow, that is huge.
And so it's monumental just trying to read them all. One wonders if it's hard for us to just keep up with reading them, then you do ask the question, did people cut corners in different places? So I think in general, I would say everyone is feeling pressure to move quickly. Many regulatory authorities are feeling pressure to lower standards, etc. And I would say we should consider lowering standards, but I'd like to be intelligent about which standards we lower. And I wouldn't frame it pejoratively. Some of the choices we make to engage in, for example, a more pragmatic design might be the perfect decision for the moment.
Thanks, Derek. I actually wanted to ask Simon just on this. So do you think there's parallels with trying to find the magic bullet for sepsis as there is for COVID?
Yeah, well, as I mentioned before, there's some suggestion of people making the kind of mistakes that we've made with sepsis over many years in terms of measure something, it's abnormal, it must be causative, rather than being an epiphenomenon or being part of the issue. Years ago, Derek and Flavia and I have been involved in the International Sepsis Forum for some time, and years ago there was a meeting in Amsterdam. I think Derek was a co-chair with Tom van der Poel, and it was a fantastic meeting. A lot of people came from the basic science world, and being a clinical researcher, striking that people would get up and they would talk about their compound or their receptor and their knockout mice model and how it improved sepsis outcome if you interfered with this particular molecule, but it doesn't translate through into clinical practice, I think, because it's a complex issue that we're dealing with. So yeah, it's a little bit worrying. I mean, I think there's been an enormous, there's a lot of good stuff. I mean, you know, if you look at the recovery trial in the UK, you know, recruit 1,000 patients in the first week of a trial. I mean, this is an extraordinary event, regardless of what you might think about some of the ways some of the things are done. But we should be learning a lot from this and being able to look at this and say, okay, this is what happens when a government gets behind a research process. And I get asked, you know, all the time, and I'm sure everyone does, who's your non-medical friends say they want to know, first of all, they wanted to know if there'd be a ventilator available for them if they got COVID, not realizing that would be a really bad thing. Hey, Simon, you'll make sure I get a ventilator, won't you? That would be a really bad thing. Then they want to know whether there's going to be a vaccine available. But everybody's heard of COVID. Everybody knows what's going on. So I think there are big positives there that we see, that what happens when someone gets behind the governments get behind a research program, funders, you know, it's disrupting other research though, you have to say this. I mean, you know, in the UK ICUs, they were told they were only allowed to do COVID research. So if you're running some research trial that you've been working on for 5 years to answer a really important question, suddenly, well, you can't do that anymore. So positives and negatives, and I'm not sure what's happening in other parts. In Australia, we didn't have it wasn't mandated, we stopped doing it, but we did stop doing research because the cognitive load on our clinical staff of learning all these new protocols, of learning how to, you know, new intubation protocols, new PPE protocols, where how are we going to cope with all this extra work, etc. That was just too much to put other stuff on top of them. So there are all these adverse effects. I think I'm a kind of Shut up.
I need to stop you because I didn't realise he was going to hog all your time, Derek.
Derek doesn't like talking in public.
So I want to go back to Derek, but thank you, Simon. So
something Simon said.
Yeah, go for it.
Am I with you or not? So Simon, this is twice now he's talked about the cytokine storm and how he doesn't think that's a very good model. I actually want to say that COVID-19 has definitely been an example of helping us see the enemy, and it is us. In many ways, it has just been us holding a microscope up to ourselves. And one of the things that I've definitely seen, just as these thousands of papers have come across my desk and the desk of the other editors at JAMA, is everyone's an expert. Everyone has a theory for COVID-19, and nearly all the time, that theory, by some magical chance, happens to be that they can apply what they know from their disease. And hardly anyone wants to stretch outside their lanes. We have really been shown up to be incredibly narrow-minded. We're so super specialized that everyone is seeing COVID-19 through their own pair of glasses. And it's a big problem for the entire scientific community. Infectious disease public health experts will say things like close schools because they know about the infectious disease, but they know nothing about the consequences of closing schools. Sepsis researchers say, what on earth are you giving this monoclonal antibody for? There's no cytokine storm. But meanwhile, the person saying it is a rheumatologist or an oncologist who knows far more about some of the, for example, ACE2 manipulation than we might know. And it's been, frankly, a bit sad to watch how little we really listen to each other. On a large scale, COVID-19 has really shown up that many of us have become so super specialized. It's very, very hard for us to think across different domains or think with any range.
So what's the solution to that?
Editorializing. I mean, the solution starts by listening. And I totally think people, they're in such a rush. It's hard for them to even hear that someone else has something to say. And I totally think that some of the research, the thousands of trials that are being logged on clinicaltrials.gov would be much nicer if there were far fewer trials, but that the research groups were all much more multidisciplinary research groups that all got together and merged their ideas and learned from each other. It's exhausting to see so many small individual efforts being proposed by people with such confidence that they know the answer, that they almost don't want to listen to anyone else.
And I think this might lead quite nicely into the JAMA editorial that you wrote around learning while doing. So perhaps you would like to talk a bit about that.
Sure. Learning while doing is, so for me, a lot of the problem here is that we're trying to do two things simultaneously. We're trying to care for patients as well as possible, and we're trying to learn as fast as possible. Now, it turns out, when you think about it, that's actually what goes on in many endeavors of life. Again, to continue the wartime analogy, when Churchill was trying to work out what to do when he came into power, he realized he was having to fight battles right there. And he also knew that the way in which he was fighting battles meant he was going to lose the war. So while simultaneously not losing the war, he had to learn how to fight the war better. And so it was not enough to say, I will fight this battle the way I did yesterday, or to say, I don't fight battles, I just invent how to fight new battles in the future. He had to do both. So here we have, 20 million cases of COVID-19, and we've randomized maybe 20,000 patients. That means that we are studying in a trial 1 in 1,000 patients. So let's just step back and imagine we were one large medical brain, one doctor taking care of every patient with COVID-19 on the planet. And we know when we see the first patient, we have no clue what this disease is. Would we really think that for every 1,000 patients, we would treat 999 exactly the way we used to know, which was nothing, because we've never managed it before, and only try to learn from 1 in 1,000? That is ridiculous. That level of knowledge accrual means we will be here for centuries before we solve this problem. We would never think of it that way. We would totally want to be learning from every patient in front of us. So why are we not doing it? We're not doing it in part because we've divided the world of medicine into people that take care of patients and people that try to learn how to take care of them in the future, which is crazy. Everyone should own both jobs. Since we're not going to instantly turn every clinician into a researcher and every researcher into a clinician, what we need to do right now is have the entire research community really think about research that isn't impossible for clinicians. They should totally think about rolling out study designs that you can do while taking care of the patient. And then similarly, then we should think when we're taking care of patients, how can we find research programs that we can meld with at the time? And otherwise, we're going to continue to study 1 patient in 1,000. That's mind-numbingly awful. So, yeah, I think that's why I think, for example, it is ridiculous, faced with a pandemic to which we do not know the answers, to stick to research designs that are going to take years to enroll a few hundred patients. It is collective madness.
So isn't the recovery trial the learning while doing design?
Yeah, so I think recovery trial is a big yes and a little no. The little no is, so recovery is brilliant for running in Britain. There happened to be lots of patients in Britain. The trial design for recovery would have been sitting there looking perfectly nice on paper if Britain was having as many cases as Australia, but there'd be hardly any people enrolled. And so one of the first things to think about is how could recovery have actually functioned as a global trial? How could it have overcome funding from different agencies, collaboration across different countries, and so forth? And then the other thing is, could the design have also worked a little bit harder to keep learning as it goes? Could it have used a randomization design where hardly anyone is in the control arm because no one wants to be the guinea pig that gets placebo? So that's the small no, that there are a few things that they could have done to have leaned in even more towards clinical care and even more enrollment. But I would say a huge yes to recovery for the thing that that Simon was talking about. Just setting as a goal, we should be trying to learn from every patient and trying to get every patient in the hospital in the trial. That's totally what we should be doing. And because of that, the researchers wanted a design that was easy for clinicians to participate in without them thinking, wait a minute, there's no time to do this. I have to go ahead and take care of this patient.
Yeah. So a question from the audience was, how do you get the balance right in respects to getting results out early versus, I guess, accurate publications?
Ah, okay. I thought you were going to talk about the balance of learning while doing.
No, we've moved on.
Sorry.
I've got to get the audience in.
Yeah. That's a great question. And it's something we're discussing all the time. So, for example, at JAMA, we are not telling authors to not post something on preprint if they don't want to. I mean, if they if they say, oh, if we bring it to JAMA, does that mean that we cannot put it up on preprint? We're sort of saying, if you want to put it on a preprint server, you can. I think everyone has seen what's happened with the preprint servers. Certain things have gone up there and they've been incredibly helpful, like the recovery trials. On the other hand, the Mediterranean hydroxychloroquine trial got posted on a preprint server and probably put the world into a tizzy. I totally believe that information wants to be free. We're just clumsy right now. So my view would be, I would keep pushing out more data and more information. And then along the way, it'll be a little bit ugly as we learn that we're not sensible about applying filters. But then there'll be human ingenuity. There'll be smarter ways of then filtering and curating the information. This is just the latest step in a centuries-old process of making information flow more quickly. And every single time there's a big change, whether it's the telegraph or the printing press or whatever, there's all these aesthete academics who think the world will be ruined when suddenly all books can be printed on a printing press, or when suddenly you can talk to someone on the other side of the country via telegraph. And every single time, maybe the world is ruined, but every single time we do it, after the initial burst of this information explosion, we get more efficient in how to curate it. So I think the balance is push the information out and then stimulate the community to think about strategies to help readers curate and distill the information better. And it totally puts pressure on journals to think about speeding up peer review. I think it makes us all uncomfortable, and it's incredibly healthy.
Excellent. Thank you, Derek. So I'd like to now move on to Flavia. So Flavia, you've always had a very different perspective living in Brazil. And so from the recent Global of Burden Disease paper, it states that the estimates of sepsis burden in LMICs are over 85%. So why is sepsis incidence disproportionately high in LMICs compared to high-income countries, and why is this same pattern not being seen in COVID?
Well, that's an interesting question. As you said, at the GBD study, we could see there was a higher incidence of sepsis in the settings where there is a lower social demographic index. Social demographic index is based on income, education, and fertility. And this is clear. And the impact of this in mortality, the difference, is even higher. So why? I believe that there are multiple factors related to the pathogen, related, for instance, we do have malaria, dengue, other infectious agents with the host, for instance, undernutrition in Africa, and mostly the inequality in healthcare system. We know that inequality is present everywhere, but it's much hard in low and middle income countries. So we have differences in prevention strategies and clean water, sanitation, access to care, access to resources, education, training. All of these contribute not only to a higher incidence, but also and mostly to a higher mortality rates. And why this is not happening in COVID? It's quite interesting. We know that on the 50 top countries in COVID epidemiology, we have 6 high-income countries, and the top one is US. So maybe one of the issues is what we see. It is the pathogen. It's a transmissible disease. So the impact of the inequalities in healthcare system might not be so relevant. And of course, Simon mentioned that most of the sepsis cases are in people under 5 and in Africa. And why we're not seeing a disaster in Africa? It's a very good question. Why not? There are multiple explanations. The first one is testing. We are just not testing because it's most of them are low-income countries. They do not have money and a structure to test. But I haven't heard about a higher absolute numbers of deaths in Africa. So I don't think the issue is testing. Maybe it's because they have an early preparation and they have an up-down lockdown in many places. Maybe they are more used to this because they have fight Ebola. They have more tracking about the contacts. But I believe that probably it's just, again, inequality. The life expectancy in US is 79 years old, and the mean age is 30 years. The life expectancy in Africa is 64, and the mean age is 19. So, except from South Africa, that now has 500,000 cases. The second country is Nigeria, with around 40,000 cases. So, except for the middle-income country over there, maybe they are not just living enough to be so compromised by COVID. As we know, COVID, we have problems with mortality in those who have comorbidities and in aged people. And but in Africa, they die below the age of 5.
Thanks, Flavia. So if we can move on just to another question for you. So the COVID pandemic has exposed many vulnerabilities in all of the world's health systems. So for Brazil, from your experience, what are the key issues that COVID has highlighted in respects to vulnerabilities?
Yeah, I believe the first one I already mentioned is our high incidence of healthcare-related infections and multi-drug resistance. Maybe the second important issue is that it highlighted our high mortality for sepsis. And I do believe that COVID is just a viral sepsis. So it highlighted our high mortality rates. We already know that, but now everybody knows it, that people are dying from it. For instance, we have EpiMed in Brazil, which is a quality indicator program that it runs in hundreds of Brazilian ICUs. They track now more than 60,000 beds, and they have already in the database 23,000 COVID patients from the private system and around 10,000 patients from public system. So the first thing we see is that it's the difference in access. So the percentage of mechanical ventilated patients in the private unit is around 40%, and it's around 70% in the public ICUs. And the mortality rates, of course, are different. When you take all the ICUs into consideration, it's around 30% in private and 50% in public. But it's interesting to see, for instance, that when you took only the mechanical ventilated patients, it's around 60% in private and 70%. So it's not so different because we do face a very severe need population. Another issue that we have now, as I already mentioned, is supplies. So we run out of noradrenaline, insulin, bicarbonate, propofol, midazolam, and this is also different. So it's not the problem that, for instance, in my hospital, they don't have money to buy. They don't have from whom to buy. And we are afraid that the access for buying things is also different from the private and from the public. So the sellers they can choose to whom they're going to sell. Another problem is the non-COVID track. So now, as Simon mentioned, it's much easier to get an ICU for a COVID patient in my hospital and in many hospitals in Brazil than a bed for a non-COVID patient. So the priority is so heavily weighted towards the COVID that we are losing more lives in the non-COVID track. And this is together with a lower, people are not seeking for care. They are staying at home because they are afraid of the hospitals. So they are much more sick when they finally arrive in our non-COVID track. And another big issue is that in middle-income countries, because of our religious practices, or maybe I don't know why, we have we are growing, we are improving in our capacity of doing end of life care. And now this is, we were improving and now we have COVID. So it's a weakness because we are not so good on that. And we need to learn, and we needed to learn fast because we have to make some choices. Well, and this is for the healthcare, but we do have another problems like our economy, fragility, corruption. Corruption is interesting. It's a plague in middle-income countries and also in low-income countries. And some hospital directors, they are afraid because they might be prosecuted in the future because they are paying 10 times, 20 times the price for the same supply about 6 months ago. So, and there is corruption, and they can be accused of corruption without being corrupted. So it's a huge problem. Not only talking about the lack of knowledge and political manipulation. I believe that anybody with an internet access knows about our president and all things that he has been doing in the last 5 months. So I believe that we had a lot of weakness that we could face at this moment. And we are trying to deal with all this.
Yeah. Thanks, Flavia. I think, so one of the audience questions is actually about how are politics affecting mortality in Brazil. I don't know if you want to make any statements on that at all.
Well, I don't believe that a single person can do so much harm. I mean, he is an unresponsible person, okay. But we do have state governments, we have the city people. So I think that we are dealing with this reasonably. So I do not blame the president or anything. I think he's just doing silly things, and we are taking care of people while he's doing silly.
Thanks, Flavia. Another audience question is, what is the basis of your diagnosis of secondary bacterial infections in COVID-19?
Well, that's a very difficult question. Well, it depends on where you are. Maybe procalcitonin can helps us, PCR. But I would say that the thing that we most use to track a possible secondary infection is a worsening of the organ dysfunction. So it's when you're looking at the bedside and seeing the patient every day, you're going to see that he's getting worse. I don't know if any validation study of any biomarker that can differentiate secondary infection from worsening of COVID infection. This is a challenge that we will have to face. And let's see. And this is a problem because we certainly are overusing antibiotics.
Simon wants to butt in again.
Flavia, I have, as you know, I have enormous respect for you and for everyone in Brazil, having had the pleasure of visiting there a few times and seeing the struggles the public health system has at the best of times, let alone I can't imagine what it's like at the moment. I guess there was one issue around sepsis, and as I said, I think that we do have an opportunity. There are opportunities here. I mean, obviously, it's kind of seems a bit weird to be talking about the positives of a coronavirus pandemic, but there are opportunities here. And one of the things, you know, apart from the fact that, you know, now people have heard of ventilators, they've heard of intensive care, this mysterious place that you just see on the television. The other thing that's been quite heartening is to see in the popular press quite a bit of, certainly here, quite a bit of comment about the longer term effects, about how people are coming out of hospital but they're not actually healthy. They're not the person they were before. And again, Derek's been involved with this work as well of trying to highlight to people that sepsis is not just an acute event. You get treated, you leave hospital, and you're fine. the data says something completely different, that, you know, maybe a third of people who were working before they got sepsis and got treated in ICU for sepsis don't go back to work, or they certainly don't go back to the work they've done before. And we don't have systems to deal with that. So I think this is, again, one of the opportunities that's come out of COVID. And I guess maybe we've not got so much inequality there, because we don't have any services for that really in Australia. And I can imagine in Brazil it'd be even harder. But maybe there's an opportunity here for us to start highlighting, saying, you know, maybe it'll have to be after the pandemic that we say, okay, all those things you talked about and all those things you wanted to fix, they're still happening, but it's just not being caused by the coronavirus. How do we fix it?
But that's a very good point, Simon. And I have a positive view of everything. I think there are some strengths that we have just recognizing now. For instance, just to mention one that is not related to your question, but for instance, philanthropy is something very strong in high-income countries. And it already exists in Brazil. But now we are seeing a completely different scenario. There are people donating a lot of money for the public health system. And we also have this that you mentioned, the recognition of the frontliners, the acknowledgement of what we're doing. Before that, when somebody asked me, oh, you're a doctor, what is your specialty? I said, intensive care. There are three options. Either they will say, what is intensive care? The second option, you're going to say, intensive care is a field of medicine. It's not just something that any doctor can do. And the third one, we're going to say, oh, we are dealing with dead people. So now it's completely different. Now they know what is an intensive care team, what we do, and also the recognition of the public system support in this pandemic. It's a much, much better. About the long-term outcomes, as you know, Brazil was struggling to do this for the septic patients. There are some nice research in Brazil for this. And I remember well a meeting of ISF, the International Sepsis Meeting, where I was speaking about this. And then I sent a question for a lot of friends in low and middle income countries. And I asked them, what are you doing about long-term follow-up in septic patients? And they answered me, we're doing nothing. So we are trying to get them out of the hospital alive. So middle-income countries, low-income countries are in a different point of this from high-income countries. You already reduced your mortality rates. Now you're taking care of the survivors. We are still struggling to get them out of the hospital. And with COVID, remember, 70% of those mechanical ventilated patients are dying in hospitals that are able to fill data, but data infinite. So I agree with you that there is an opportunity here. As I said, now the numbers of deaths of this viral sepsis is much more recognized. Our role on this is much more recognized, but I'm not sure that we're going to be able to deal with specifically the long-term outcomes of COVID patients. Although I agree, it's a good opportunity to highlight this important issue.
Thank you, Flavia. I think we now need to wrap this up. I would have liked to ask you all a lot more questions, but we're running out of time. So thank you to our online audience for participating. A big thank you to our sponsor, MSD, for making this session possible. And an enormous thank you to our experts today for giving up your time and parting with your wisdom to leave us with a lot of food for thought. So thank you, stay safe and goodbye.